Alrighty, week 6, path, O2, vessels, and blood pressure. So most of this is review. Red blood cells is an important part. Red blood cell production requires the intake of iron, B12, folic acid, and proteins. So anytime that we've got reduction or inadequate intake of these guys here, then we're looking at potential impact to red blood cell production. All of this is pretty straightforward. Gas exchange is pretty straightforward. Okay. So when it comes to the creation of red blood cells, going back to AMP, when there's a decrease in O2 delivery to the renal cells, I think they're, which ones? Juxtaglomerular cells, or maybe there's something else. Some cells in the kidneys, when they detect that there's a lower level of O2 than what there should be, then they're going to start increasing their secretion of erythropoietin. And erythropoietin is what's then going to tell the red bone marrow, or the bone marrow in long bones in children, and I think it's flat bones in adults, to start producing more red blood cells, creating more erythrocytes. And this is a negative feedback loop. So when the kidneys start to recognize, hey, we don't have enough blood, or O2, more like, then they're going to send erythropoietin to the bone marrow, and it's going to create more red cell mass, and then once it comes up to par, they're going to shut down. So with the feedback mechanism for anemia, the body's going to recognize, or the kidney's going to recognize, there's not enough red cell mass, increase erythropoietin production, and we're going to have more red blood cells. For hypoxia, we're also going to have an increase in red blood cell production because it's not necessarily because there's not enough red blood cells. It could be that there's something else going on. Maybe there's a person living up in Colorado, Denver, where there's not as high a partial pressure of oxygen in the atmosphere, and so the body's going to kick up their erythropoietin production to try to address the lack of oxygen. And then there's also the pathologic production of red blood cells in the way of polycythemia vera, where I don't remember exactly why, but the bone marrow produces too much red blood cells and doesn't listen to the negative feedback from the kidneys, and you've suddenly now got this super high blood pressure and super high blood viscosity, and things get bad. So anemia is going to be basically that you don't have enough oxygen delivering as like a current state of not enough ability for the blood to carry oxygen to the tissues for some reason. And most of the time it's because of a deficit of red blood cells. So we can have two different types. We can have relative or dilutional anemia, which is where we're going to have a normal red blood cell total, but the plasma volume has increased. This is what you're going to typically see, for example, with pregnancy. You can also have absolute anemia, where we have a decreased number of red blood cells. And then absolute anemia can kind of be broken down into three classes of anemias. We can have a problem with the production of red blood cells, so that we have a decreased production. We can have inherited disorders of red blood cells, so that's going to be like our thalassemias and sickle cell anemia. And then we can have extrinsic red blood cell destruction or loss, like with hemorrhage. In general, clinical manifestations for anemia is going to be the same across the board. There are some differences in specific manifestations, but they almost all have the same core kind of problems, regardless of the type of anemia. And it's all related to the fact that there is a decrease in O2 in the tissues, leading to hypoxia and compensatory mechanisms. So early on, there shouldn't be any problems. The body will be better able to compensate. It may not even be enough of an anemia to cause symptoms, But as it progresses, then the person's going to have issues with fatigue, weakness, and dyspnea because they're going to feel like they don't have enough oxygen. Um, and their body's mechanisms, compensatory mechanisms, are going to start kicking on. Eventually, they can have hypotension, which really that's more specifically with those who are experiencing anemia because of acute blood loss, and syncope, both from blood loss and maybe also from a lack of O2. Tinnitus, intermittent claudication, which is going to be pain or cramping that comes on from a lack of O2. Not enough O2 really to meet the oxygen demands of the muscles that are firing. And then eventually you can get angina because with a lack of O2, the heart becomes ischemic, leading to chest pain. So we test for angina with a CBC, which are these guys here that are virtually impossible to see. I don't think it translated well to the PDF. We have another version over here that might be a little bit better to look at. So with CBC, some of the things that we're going to be looking at is going to be hemoglobin, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin. Mean corpuscular volume will also be abbreviated MCV. MCH would be that mean corpuscular hemoglobin. MCHC would be mean corpuscular hemoglobin concentration. Red blood cell distribution width, and reticulocyte count. So hemoglobin, we're just doing a direct measure of hemoglobin, how much of that is in the person. Hematocrit is going to be the percentage of the blood that is red blood cells. Typically, we're thinking about 45%. Mean corpuscular volume. A corpuscle is, I believe, also another term for a red blood cell. And so what we're really looking at here is what is the volume, the average, the mean volume of a red blood cell. So by looking at that lab result, we'll be able to see whether a person's red blood cells are smaller than average, larger than average, or just the right size. And knowing which one, we'll be able to tell what kind of a pathology is going on here. And then smaller than the size they should be would be microcytic, or larger would be macrocytic, or megaloblastic, and then normocytic would be normal. And then mean corpuscular hemoglobin is going to be the average amount of hemoglobin in an average red blood cell. I still somewhat struggle with understanding the difference between that and mean corpuscular hemoglobin concentration, which is the average concentration of hemoglobin per red blood cell. Yeah, that's still figuring that one out. Red blood cell distribution width is a good thing in that it measures a variation in, it's a good thing, measures a variation in red blood cell size and width. So we want to have a more homogeneous distribution. We want almost all of the, if not all of them, the red blood cells to be the same size no matter what. When we're seeing that patients have pretty heterogeneous or like really varied differences in sizes between one red blood cell and the next, then we know there's a problem going on. Reticulocyte count is also really important because reticulocytes are immature red blood cells, and they normally only make up about 1% of blood because they're just there to try to replenish the red blood cells that die at the end of their 120 days. Just make sure that we're keeping up on red blood cell quantities. In times where there is more red blood cell destruction or loss, then where do they come from? Bone marrow probably is where they're hanging out. Then they will be released in greater proportions, and that will be an indication that there's something wonky going on that warrants checking out. Okay. So, and also something that's good to get familiar with are these lab skeletons. And they're actually, I don't remember, they're also called like fishbone labs. Don't remember where I found it, but there's an awesome one to look at to help memorize like the 4 or 5 most common skeleton lab, fishbone lab things. I'll have to post that somewhere. So for absolute anemia, we're going to start with red blood cell production, um, which can come in the way of iron deficiency, which is going to be our most common form, B12 or folate deficiency, under which pernicious also falls, aplastic anemia, and then anemia that comes from chronic renal failure. So iron deficiency anemia is actually pretty common, but it's most common in the undeveloped or underdeveloped countries. So 50% of people, the population in underdeveloped countries, have iron deficiency anemia, whereas in developed countries, it's as low as 10% or lower. And the idea here is that there's just not enough iron, hence the name, and that can come from a lack of iron intake, or there's a decrease in the absorption of iron. That can come from a chronic disease, perhaps, or an increase in iron loss through hemorrhage, bleeding. Nope. So some of the risk factors that we're looking at here is being female, because you, as a female, you menstruate, lose blood. That right there puts you at higher risk of being iron deficient because you're losing blood with, or iron with that blood. But especially those that have a higher flow or a heavier flow, you're losing even more. Being older is a risk factor because they may have a lower quality diet. A lot of times iron comes in the form of meat, and if you are unable to chew and process that meat in your mouth or unable to digest it, maybe you have GI disturbances that come from eating that meat, then it'll be more difficult to get access to the iron in the meat. They also have a decrease in hydrochloric acid production. There we go. And having a decrease in hydrochloric acid in the stomach can lead to a decrease in iron absorption. So that iron, the hydrochloric acid, is an important part of iron absorption. Colon cancer, one, will cause blood loss, and then also if you have a part of your colon taken out, then that leaves that much less to, actually I don't remember if colons are where they absorb it. Colon cancer causes blood loss. It's also the most common first sign, being iron deficiency anemia is a common first sign for noticing that someone may have colon cancer. So something to think about for assessments or noticing or documenting. Poor dentition will, as being older, potentially lead to iron deficiency anemia just because you don't have the ability to chew, masticate the food that the meat that you're eating. And if you can't chew the meat, you're probably not going to eat the meat, and you're not going to get as much iron. Peptic ulcer disease is a common form of iron deficiency anemia because you're bleeding. Nutritional deficits, such as vegetarians, vegans, are at risk because they don't eat meat. Perhaps cooking in a cast iron skillet, which leaches iron into your food, or taking iron supplements can help. But a lot of people don't do that and are unaware of the impact of having a vegetarian diet can have on your iron levels. Chronic illness, hemodialysis, hemorrhage. Different chronic illnesses can lead to more bleeding or lack of absorption. Hemodialysis, because you're leaching out iron as the red blood cells are going through all that tubing, and hemorrhage, of course, because we've already covered that. Okay, so with iron deficiency anemia, the red blood cells are going to be microcytic and hypochromic, and that's actually something I meant to cover. Anemias can be described as being what does the look of the red blood, what does a red blood cell look like because of this anemia? So the red blood cell could be small, normal, or larger than normal. It could also be the normal color, normal chromatic, or normal chromic, or it can be hypochromic, being that it has a less red, more pale kind of look because of a lack of iron or lack of heme, which would be because of iron. So normally you'll see that in some levels of, or some charting from lab results. So the clinical manifestations are going to be the same as normal. They're going to be weak, low exercise tolerance, maybe dyspnea, tachycardia. But people with iron deficiency anemia also have an unusual manifestation of pica, which is a craving for non-food substances. I don't know why there's a ferret here. Don't eat ferrets. But like non-food substances like chalk or clay, weird kind of things that you just normally don't want. Oh, no, that's where this is supposed to be. You get to, wait, no, you get to come, all right, stop it. Whatever, I'll fix that later. So things like ice, clay, starch, chalk, dirt, or other material that's meant to be up here are forms of pica. Other manifestations also are going to be cold intolerance and hair loss from that lack of iron. So we're going to, trying to figure out why that ferret's there. So we're going to want to teach about the etiologies for this. So if the person's got a vegetarian diet but not doing anything to supplement their iron, then we can teach about how that creates anemia. In which case we then talk about diet education so that we can ensure they have enough. Maybe we need to do some iron supplementation, but if we do that, we also got to make sure that we are including vitamin C, since vitamin C is important for promoting iron absorption. And then anytime we are looking at an older person with iron deficiency anemia, we always want to check for occult blood or perform a colonoscopy because they could be leaching out blood into the GI tract through their feces and may not have any clue of that. Okay, so B12 and folic acid. Let's see here. So red blood cells require B12 and folic acid or folate for DNA synthesis. And I think it was in one of the earlier slides, recognized that one of the types of antibiotics that we can use were folic acid blockers or inhibitors, inhibitors of folic acid, because bacteria are able to synthesize their own folic acid, whereas we take it in ourselves, but both ways, it's required for DNA synthesis. Folic acid itself is required for the synthesis of DNA, and B12 is required to basically ensure that folic acid remains in its active form. Folic acid kind of wants to go through a few different pathways, most of which are not functional towards creating DNA, but then B12 comes in, whips it into shape, and tells it to stay on the straight path towards DNA synthesis. And so if we have a deficit in either B12 or folic acid, then we're looking at an inability to create that DNA and leading to DNA or B12 deficiency anemia. And what will happen is they'll actually become macrocytic red blood cells. So they'll be larger than normal. And I believe the reason for that is because what was it? Because part of that DNA was limiting, like it wasn't given the instructions to separate. And so you kind of have like these just massive red blood cells instead of the normal sized red blood cells because of the inhibited cell division. Part of the problem with that also is those massive large red blood cells have difficulty leaving the bone marrow and they have more difficulty squeezing through tight capillaries. The people who are most at risk for this are going to be European and African descended people, people who have a vegetarian diet or a poor diet, those with alcoholism, older adults due to malabsorption issues, those who've had bypass surgery, again due to a malabsorption from a decrease in surface area. All those people are going to be at risk for B12 deficiency. Folic acid deficiency is going to be generally pretty rare in the US because we have such a priority on, I just lost the word. We put folic acid into a lot of foods, and we enrich foods with folic acid. I think that works. But it can also come from any condition that inhibits GI absorption. So being older, having bowel diseases, chronic inflammatory diseases of the gut, taking certain medications, again, being alcoholic, or being pregnant or lactating due to the nutritional needs of the fetus or infant can all lead then to fibric acid or folate deficiencies. Pernicious anemia is specific in that it refers specifically to insufficient intrinsic factor. So B12 deficiency and folic acid deficiency are not specifically pernicious anemia. Pernicious anemia kind of falls under that kind of like a B12 deficient anemia umbrella, but it talks about a specific pathway, whereas general B12 deficiency can come from those multiple different types of absorption issues or what was the other ones? Bypass surgery, all of that stuff. So when it comes to pernicious anemia, B12 requires intrinsic factor, which is a stomach protein, for absorption. So we take it in from our, I think it's like leafy greens. I think actually it's also meat. So meat, leafy greens, they come into the body and they require intrinsic factor, which is secreted by parietal cells in the stomach, to be absorbed. So if they are unable to, then we're not going to be able to create the DNA in the red blood cells that we require. The cells do not properly divide like they're supposed to, and suddenly we have these massive, too large red blood cells, and we have a decreased number of cells as well. I think this was a better diagram of what's going on. So we take in our dietary B12. These little guys here are B12. They come in. These guys here are the normal intrinsic factor proteins that are secreted by the stomach. They bind together like this into this little capsule-looking thing. They go down through the stomach to the small intestine, where they are able to be absorbed in the ileum because of intrinsic factor, and everything's great. Whereas in pernicious anemia, there are actually antibodies against intrinsic factor that basically make it so that the destruction of the parietal cells here, they don't release the intrinsic factor the way they're supposed to. So B12 stays in here, goes through the gut, but it can't cross through the ileum, and so instead it just goes through, and we all know where that goes. It just goes out in poop. So some of the risk factors we already covered. Diet insufficiency. Pernicious anemia is a little different in that that's just the intrinsic factor, and an autobody or an autoantibody, not an autoantibody, and like an autoimmune issue limiting the production of intrinsic factor. For regular B12 or folate deficiency anemia, that can come from certain medication use or diet insufficiencies, being older, in that can decrease intrinsic factor production. We can have endocrine-related diseases increase the risks in that, like biguanides, like metformin, can decrease B12 absorption. And then if we're limiting how much of the stomach and ileum are available for either producing intrinsic factor or absorbing B12, then we're looking at pernicious or B12 anemia, depends on which part we're looking at. Yeah. Okay. So some of those manifestations that we're going to be thinking about will be the same as general. These ones are going to be more likely to have a sore tongue or glossitis. As we can see here, it kind of also extends somewhat to the mouth. Um, Peripheral nerve degeneration can also present as like paresthesia from neuropathy. Going to feel like numbness and tingling in the hands and the feet. Weakness due to an unsteady gait and balance problems because of the lack of oxygen. And then these patients also can experience dementia and acute psychosis. So it's not really dementia, it's more like um, a memory impairment and depression that can kind of mimic dementia, and it's called megaloblastic madness. And that can come because of those megaloblastic or macrocytic super large red blood cells that inhibit how much of the brain can actually be supplied with oxygen. Because if those red blood cells are massive, they're not going to be able to as easily go through the capillaries, those really tiny capillaries, where normal red blood cells are already having to kind of squeeze to get through. They're just going to get stuck and not make it through. So what we're going to do is, it depends on which form of B12 folic acid deficiency anemia they have. If they straight up can't get B12 through their gut because of pernicious anemia, where they don't have intrinsic factor, then we may just give them straight up B12 injections. Or maybe it'll be oral if it's a mild deficiency. Otherwise, we might be looking at doing more dietary education, lifestyle factors, try to improve the natural stuff. Aplastic anemia, this is going to be a stem cell disorder where there's damage to the bone marrow, and it doesn't create, thought I heard something, it doesn't create blood cells the way it's supposed to. So 80% of cases are acquired through hepatitis or HIV, Epstein-Barr, radiation, chemicals, certain drugs, or immune disease. So 80% of these are acquired. Some of them, of the 20%, some are familial, and you pass down from one family, one generation to the next, and then the rest, they just have no freaking clue where they come from. But the big thing here is that we've got these big old fat cells that come into the bone marrow that take up space and make it so that there's not as much room in production to create red blood cells. So there's a decrease in stem cell tissue, which is all these guys here, because those big old fat deposits are in there. I think these are meant to be replaced or switched. Leading eventually to pancytopenia. There's just simply not enough at all to begin with in the bone marrow, so all the different types of bone cells are going to be reduced in their quantities. So fewer red blood cells, fewer white blood cells, fewer platelets. Okay. Maybe I misunderstood. Maybe it's a matter of there's not enough stem cells to begin with, and then there's a lot of big fat pads that are kind of created, and that's how we can identify it as being aplastic, is that we notice these are in there because there's nothing else to take up the space. Regardless. So this is going to be more common for those who are between the ages of 15 and 25 or over 60. I don't know why. Toxin exposure, so that certain medications, certain antibiotics, no, did I say antibiotics? No. I guess certain drugs, like sulfonamides, have an increased risk of developing aplastic anemia, and I already covered that, and pregnancy. So we're going to have the same general manifestations for aplastic anemia as the others. They're also going to have fever and chills, and they're going to have a higher risk of infections because they have a decrease in white blood cells. And I guess they're more common with oral or perirectal areas. And because they have a low level of platelets or thrombocytopenia, they're going to have a chance or greater chance for petechiae, that sort of pinpoint bruising that occurs, regular bruising, and bleeding. The only real treatment for this is going to be bone marrow transplant to try to get those stem cells back. So as we can see here, this is normal bone marrow, very thick, very dense, full of stem cells. Whereas aplastic bone marrow, these are all the fat deposits in here. We still have some of the stem cells and red blood cell production areas, but it's nothing compared to what we normally have. So next we're going on to inherited disorders of red blood cells. So we've got first our thalassemias. These are going to be occurring due to an inherited genetic defect. So normally we've got hemoglobin, which is made up of 4 polypeptide chains. Do I have a picture somewhere? No, I should have gotten a picture. So just for reference, we've got these 4 polypeptide chains, 2 alphas, 2 beta chains. They hang out together and they give good surface area for the blood cell, for oxygen to bind to, and we're all hunky-dory. In thalassemia, there's a gene mutation that causes some of the proteins to become abnormal or just full-blown missing, leading to one of the polypeptide chains themselves to be missing. So instead of having 2 alpha chains and 2 beta chains, one of them will be missing, so maybe we'll just have 1 alpha and 2 beta, or 2 alpha and 1 beta. And that's basically it for thalassemias. And they'll be classified, therefore, as being an alpha or a beta thalassemia, depending on which one is missing. And because you're having a giant chunk of hemoglobin taken out, or the globin, I guess, of the globin taken out of this production of the red blood cell, that's going to cause the red blood cells themselves to be smaller, making this a microcytic anemia. We also have our sickle cell anemia, which is due to a gene mutation, as we'll get to here. There's a mutant beta globin gene that leads to an abnormal hemoglobin production, specifically hemoglobin S, S for sickle. And then anytime that we have a stressor, any person with sickle cell anemia, anytime they have a stressor or hypoxic event, that will take a number of their normal red blood cell shaped cells and make them suddenly sickle shaped. So we're not talking about like at all times, it's not a guarantee that at all times people with sickle cell anemia have sickle cells flowing through. It's a response to some kind of a stressful situation. So some of the sickled red blood cells are hopefully hemolyzed and recycled back into healthy red blood cells, but a lot of them remain in circulation where they can then pose a risk for capillary occlusion, or which is what we call sickle cell crisis, or they can get stuck in organs somewhere and cause organ ischemia and organ damage. With repeated episodes of this sickling, more red blood cells are going to end up staying sickled, which means that one of the things we need to teach about is as much of a stress-less lifestyle as possible. Maybe get your Zen on with some yoga or Tai Chi, whatever. But the idea is the more times that these patients experience super stressful experiences or hypoxic events, the more trouble they're going to have. Part of the problem also is that with sickle cell anemia, these sickle cells only last about 10 to 20 days instead of the 120 days that they normally do. So they're going to have a very rapid rate of hemolysis. Those red blood cells are going to be destroyed in the spleen, and because they're seen as being really, really bad. And so not only are those cells that are there instead of the healthy red blood cells unable to hold as much oxygen, they're also going to die and get destroyed much more quickly, making the anemia even worse. And there's also a good chance that these patients are going to experience splenomegaly, the enlarging of the spleen, just because of how overworked the spleen becomes. So, okay, good. There's also hereditary spherocytosis, which is evidently one we got to know. And this is caused by a lack of membrane proteins in the red blood cells, which basically means that normally we have like these proteins inside or on the surface of red blood cells that give it its biconcave shape. And without those proteins, the red blood cells can't maintain that shape and instead become more of a spherical shape. And they become that kind of macrocytic anemia because they are larger cells than they normally would. And then they become anemic because the spleen's constantly trying to get rid of them because the spleen's like, these are not good red blood cells. And the spleen becomes splenomegaly. And we don't have enough red blood cells left in the body to carry oxygen. Okay. So with these sickle cells, normally we've got, they go through, they squig around and whatnot, and we're all good. But when they're this weird sickle shape, they can get caught in these bifurcations much more easily and can cause painful crises, like a sickle cell crisis. And so we can end up with organ dysfunction, growth retardation, and bilirubinemia, which can lead then to jaundice because of the excessive red blood cell destruction. So what we're going to do is we want to prevent vaso-occlusive crises as one of the top things we do. And we do that by keeping hydrated because the more diluted our blood can get, the better that it can prevent those red blood cells from kind of bunching up. We also want to decrease the chance of fevers. I can't remember why. Decrease the risk of infections and cold exposure. I guess all of those things cause stress, is what it was, which can then lead to more red blood cells becoming sickle-shaped. And then cold exposure can then also lead to vasoconstriction, making it more easy for sickle cell crisis. We also want to provide pain management during those crises. These can be very painful and occur throughout the entire body, so depending on the stressor and the type of event. So we want to make sure we're really doing good pain management. And then long-term, really the treatment, there's no cure, but treatment is going to be bone marrow and stem cell transplants. So we can also then have the last class, which is extrinsic red blood cell destruction or loss. This can come from just plain acute blood loss, so GI, or maybe it's a colon cancer, or literally someone gouged a hole in your gut. Acute blood loss, red blood cell loss. We can also have hemolytic disease of the newborn and antibody-mediated drug reactions, which we'll get to in a second. So we've had trauma or surgery or disease process leading to just loss. So with acute blood loss, the clinical manifestations for this form of anemia is going to be the same as general manifestations of anemia. When we're looking at 20 to 30% loss, we're looking at tachycardia with exercise. Not really exercise, you start doing things that normally wouldn't make you tachycardic, now suddenly you're tachycardic. Also experience orthostatic hypotension. With 40% loss, we're looking at a decrease in blood pressure at rest and a decrease in cardiac output. And then if we're looking at greater than or equal to 50% loss, shock and death. According to the book, if we have 15% or more, we're going to experience orthostatic hypotension and anxiety. 15 to 30%. This is where we're going to start having compensatory mechanisms like tachycardia, oliguria, maybe start seeing some mild changes in our level of consciousness. 30 to 40%, we're going to see hypotension, paleness, a weak rapid pulse, and then anything over 40%, we're going to start experiencing profound shock, confusion, maybe complete loss of consciousness, and generally a heart rate above 140. So just some book examples they had. For hemolytic disease of the newborn, this is going to be where we have incompatibility between the blood type that the baby has compared to the blood type that the mother has. So the mother perhaps has and we'd have two different types. You can have one where it's either an A, AB, B, or O incompatibility, which luckily this is the more common type and is not quite as risky or significant. But the other form is the RH or rhesus incompatibility, which is more rare but more severe. Either way, let's say the baby has type B blood and the mother has type A blood. They're incompatible, and so exposure of the baby's blood to the mother will result in antibodies being designed or made against the baby's blood, which for the first baby shouldn't be a big deal because typically that occurs during birth. But on any subsequent births, we're looking at a higher risk of automatically having antibodies created to the baby's blood, killing the baby. Same idea with RH. So let's see here. So we're going to have the same kind of manifestations as other forms of anemia in the baby. They may also have petechiae, hepatosplenomegaly, because they're trying to work with all of this now dead blood in their body. They may experience heart failure from a lack of oxygen in the heart, trying to pump harder as well. Kernicterus is going to be where they have this excessive bilirubin from the destruction of red blood cells, and they're going to become all yellow. And then also because they have, so there can be jaundice there, but then also all of that bilirubin is capable of getting into the blood-brain barrier or crossing through the blood-brain barrier into the brain, causing kernicterus, because that blood-brain barrier is a lot more permeable than what we experience or have as adults. And that can lead then to baby death or fetal death. God, that sounded awful. So with nursing interventions treatment, I gotta say, this baby just looks pissed at the mother. It's like, you jerk, you did this to me. So one of the things we're gonna do is give the mother RhoGAM. We're gonna give it to her either before or after the first delivery for the purpose of destroying the infant red blood cells in the mother, so that the mother does not get sensitized. For a little while there, I thought they meant in the baby, and I was like, I don't think that's what we want to do. That kills the baby. We also can have antibody-mediated drug reactions, where drug exposure causes an antibody synthesis and destroys red blood cells, which we can see here with these little half chunks. I don't know what kind of drugs we're talking about here, but I guess it's kind of just the body looks at a drug as being suddenly, we don't like that, and sees the red blood cells as being that type of drug and kills it. So we're going to have the same kind of general symptoms, and the severity of which is going to depend on how strong of a reaction our body has. So, I mean, number one, really, of course, stop the freaking medication. Just don't give it to them, because we don't want them to die. And they may need transfusion just to get rid of more of those red blood cells, get in more good red blood cells, all that. So this is kind of a fancy good chart that shows if you're looking at the mean corpuscular volume, literally just the size of the individual red blood cells. If we have low, which is microcytic, normal, normocytic, and high macrocytic as a piece of the puzzle in determining what kind of anemia a patient has. We can remember that macrocytic anemias are going to be from like B12 deficiency or folic acid deficiency and some other stuff. Normocytic anemias could be like a hemolytic anemia, like hemolytic newborn anemia, bone marrow disorders where it's a matter of just simply not creating enough bone marrow, or not bone marrow, red blood cells, but there's no real difference in the quality of the blood cells that are created, or acute blood loss, or from chronic disease just bleeding out inside, like peptic ulcer diseases. Or then if we would have microcytic anemias, then we're looking at like thalassemias or iron deficiency anemias. Yeah, so it can help with as being like a key or like a piece of the puzzle towards identifying which anemia is it that we're working with. Polycythemia, this is rare. We're just having an excess of all different types of blood cells, but the main problem here is red blood cells. The blood becomes much more syrupy, much higher in viscosity, and can lead then to hypertension. Really all we're going to do here is we're going to do more phlebotomy. They're going to come in on a regular basis. We're going to poke them, get a bunch of blood out, give them more fluids perhaps, give them aspirin to prevent the extra platelets from clotting, and then maybe they'll take medications to suppress the bone marrow from creating so much extra stuff. All right, so blood vessel and pressure pathophysiology. So peripheral vascular disease is basically just the disease, makes sense, of the peripheries. A lot of these come from a problem with a thrombus, which is going to be a stationary blood clot. Most often can come from like a atherosclerosis, which we'll get to in a second. Embolus becomes a traveling thrombus, so the thrombus develops in a spot and it's a thrombus, but once it kind of releases from that spot, it becomes an emboli. Thrombophlebitis is a form of vascular disease where there's just inflammation to the thrombus and the vein. And then Virchow's triad is a combination of, okay, so this kind of was confusing to me when I first learned it. I was under the impression that you had to have all three to create a thrombus, but evidently Virchow's triad is, they're each individual factors that themselves are the most, like the highest risk factors for developing a thrombus individually. But most thrombuses have some overlap between one or the other. So anytime we have stasis, that's an increased risk for a thrombus. Anytime we've got vessel wall injury, that's an increased risk for a thrombus. Anytime we have hypercoagulability, that's an increased risk for a thrombus. But a lot of times, like with atherosclerosis, we can have both vessel wall injury and stasis, which will just simply increase even more the chances of developing a thrombus. So anytime we have altered blood flow of any kind, that will lead to stasis. Not only will that have the reduction in systemic blood flow and impaired gas and nutrient transport, but it will also lead to an increased chance of a thrombus. Okay, so peripheral vascular disease itself is broken down into being either arterial dysfunction or venous dysfunction. It actually can be peripheral artery disease, or PAD, or peripheral venous disease, PVD. There are lots of different etiologies for how someone can develop PAD or PVD, but generally the presentation is going to be the same. So let's say, for example, we got an obstruction in the left leg, like a clot or a really serious case of atherosclerosis in a certain part of the leg. So the general problem here is that, and actually this came from a video, that's right. So we've got the heart here, and then we've got an artery going out to the legs, and there's a clot in the leg, and then we've got the veins coming back from the leg to the heart. So there's a problem with blood getting to the leg because there's a clot. So the problem here is that there's going to be a lack of oxygen and a lack of nutrients getting to the leg. The venous return to the heart from the leg should be just fine. It shouldn't be a problem whatsoever. There may be a reduction in the volume of blood coming back from the leg to the heart just because there is a reduction in the amount or volume of blood coming from the heart to the leg, but it should still be just as easy to bring blood from the leg back to the heart. So what we're going to experience here is pain, specifically two different types of pain, intermittent claudication and rest pain. So intermittent claudication is going to be where, because there's a lack of flow from the heart to the leg, when a person starts to exercise, if it's severe enough, maybe just simply moving the leg, walking from one place to the other, you're going to increase the oxygen demand of the muscles in the leg that are being served by that vessel, and they're going to not get the oxygen they need, resulting in pain and cramping. So that's what intermittent claudication is. And then rest pain is something that these patients can also experience, where because you already have it's already difficult to get blood to the leg because of that clot. When a person goes to lie down in bed, or they've got their feet propped up on a leg rest or something, especially if it's above the level of the heart, then suddenly we have a really massive reduction in blood flow to the leg. And so that can lead to pain, mostly from the perspective that there's just not enough oxygen going to the tissues in the feet and leg. But then once they kind of slide their leg on over the bed, or they stand up and allow for blood flow to at least better get to the leg, then they feel better. They also have a distinct kind of color problem with this leg. So when we take a patient who's got a thrombus in their leg, or some sort of an obstruction, and we lift the leg up, then their leg eventually is going to go pale. For like normal people, it should really only go maybe a little bit pink, because the heart and the blood vessels should allow for perfusion to go mostly just fine. But for these people, any additional like gravity-fed obstructions to blood flow perfusion is going to make the lower leg look white. And so that's going to be called elevated pallor. When you swing that leg down over the bed or bring it back down under the heart, then the leg is going to regain color like normal. But if we're talking about having a pretty severe case of peripheral artery disease, then their leg is slowly going to become more reddened. And this occurs mostly because the arterioles and the capillaries are so used to desperately trying to get blood to the leg that they've lost their sense of being able to contract. And so you lose it. If you don't use it, you lose it. And so now the leg can kind of swell a bit and become reddened. And it may take a little while before the veins kind of bring up all the blood that was in there. You're also likely to see between the two legs a difference in pulses, depending on where the clot is. So you may feel a much stronger pulse in the right leg compared to the left leg, which would indicate a problem with perfusion. And then something important to take mind of is there's something called an ankle brachial index, where we take the blood pressure in the upper arms, compare it to that of the ankles. Normally the ankles should have, just because of gravity, a higher blood pressure. But if they have a lower blood pressure, then that indicates peripheral artery disease. And then the lower leg is also likely to be more cool to temperature, poikilothermia, have poor hair growth, dry skin, and thickened nails. For peripheral venous disease, let's say the patient has venous insufficiency, there's a problem with delivering blood to the leg, or there's no problem with delivering blood to the leg itself, but there's a problem with sustaining blood flow back to the heart via the venous system. So for these people, instead of like a sharp pain that they experience because of a lack of oxygen or because of that clot developed inside of the vessel, these patients are going to experience more of a dull, constant ache. The pulses should be equal because the arteries are not obstructed. They're able to go down there just fine. They also will likely have warm temperature because you got blood flowing from the arteries just fine. They are likely to have, though, pedal edema because there's an obstruction to getting blood up through the veins. These patients are likely to experience stasis dermatitis because when we get this venous blood flow kind of pooling around in the leg, that extra or like super excessive hydrostatic pressure that comes from just the pooling of the blood, as well as the continued pressure from the heart pumping down blood through the arteries, promotes some of the red blood cells to actually self-destruct, basically. And when they do so, they release what's called hemosiderin, I think I'm saying that correctly, which is really the pigment in hemoglobin. And that pigment will then kind of seep out into the interstitial spaces and then get deposited into the dermal layer of the skin, making the skin look brown. So a lot of that stuff I got from this video here, which was really helpful. Google PAD versus PVD was really good. Back to the actual thingies. No, what did I do? Okay, there we go. So etiologies for arterial forms of peripheral vascular disease. So we can have a blockage of some form, acute arterial occlusion, such as with a thrombi or emboli. Atherosclerosis and arteriosclerosis are the most common forms of arterial occlusion. Inflammation, which really also kind of plays its part in atherosclerosis, but can come in other forms as well. Spasming can occur. That can occur, for example, in coronary arteries, which is how we get certain types of angina. I think it was called Prinzmetal angina. And then we can also have mechanical alterations such as arteriovenous fistulas, where the artery actually just goes straight into a vein instead of going through a capillary network. And then aneurysms, where, did we even talk about that? No, we don't. Okay, aneurysms. Okay, so arterial sclerosis is different than atherosclerosis. Arteriosclerosis is going to be where the arteries become thick and stiff as like a general idea. Atherosclerosis talks about the development of plaque from that thickening, or thickening and stiffening is kind of like a natural thing that happens over time. Atherosclerosis is going to be an inflammatory response where plaque ends up getting developed and there's a risk factor for clot formation as well. So there's some form of an endothelial surface damage to the endothelium, hence endothelial surface damage, such as high blood pressure, the shearing force of high blood pressure, high levels of blood glucose, number of things that can cause it. That creates an inflammatory response, which makes the wall more permeable. As the wall becomes more permeable, did I write anything down on this? I don't know. So as this wall here, this is the inside, the endothelium, and with some form of an inflammatory response, it becomes more permeable. As it becomes more permeable, the LDL molecules that we have just naturally going through our blood ends up getting deposited under the endothelium, which is what these yellow bits, yellow area here is. That kind of develops, which when that happens, We have macrophages that come in. Macrophages here, they come in and they start engulfing LDL molecules. As they engulf LDL molecules, they also will tell the body to continue that inflammatory response because they're like, holy crap, there's a whole bunch of LDLs in here. And the LDLs will continue as well to get deposited into this plaque area. Eventually, they'll kind of die and form foam cells. Foam cells may also be while they're alive, I don't remember. But basically, they just get engulfed in, or they get filled up with LDL molecules. And they just get trapped in this area as well, and they just keep on building up and building up and building up. The body is going to recognize the smooth muscle, pretty much, recognizes that this is an unstable area at risk for developing a clot. So they're going to, the smooth muscle cells are going to invade this area, this fatty area full of foam cells and LDL molecules, and they're going to start to deposit calcium as like a rigid network to try to work as like a matrix to keep things steady, and they're also going to form then this fibrous cap to try to prevent that from floating away. But there are going to be times, more than likely, I don't know if more than likely, but I think it's more than likely, where there's going to be some sort of a trauma to that fibrous cap, opening up the atherosclerotic plaque to blood, which is going to think this is an injured area, we got to form a clot, and it's going to keep on building and building and building, and suddenly now we've also, not only do we have obstruction to the artery because of this plaque, but now we've got a clot, a weak clot forming on the top of the plaque that can easily dislodge and travel downstream to form any number of occlusions. So this is what people are going to look like when they have some kind of a arterial flow problem. So, and actually this is interesting in that these are, both of these legs kind of show different parts of it. So if we were to take this person's left leg and lift it, this is kind of what it would look like. It would look kind of more dusky, pale, because that blockage in arterial flow is going to be made even worse by gravity when we lift the leg up. But when we put the leg back down with really kind of severe arterial occlusions, then they start to develop this dependent rubor, and this was elevated pallor. This dependent rubor shows up because now suddenly they have this rush of blood into arterioles and capillaries that have lost their ability to contract, making it much more red and swollen. So these patients can also have painful ulcers just because of the lack of blood flow leads to neuropathy. They may not be aware of wounds down there, as well as they don't have enough blood flow to heal any wounds that could be down there. Their legs can be cold, decreased hair, dry, glossy. The nails are going to get thickened, have that dependent rubor, and decreased pulses. Okay. So the biggest risk factor for this is smoking. We always want to talk to our patients about try to stop smoking. But other things that can also lead to atherosclerosis are increased levels of LDL, decreased levels of HDL, because LDL brings cholesterol to the blood vessels for injury making, whereas HDL takes them back to the liver. So yeah, we want to have high HDL and low LDL. Increased triglycerides, increased platelet aggregation, all that stuff. Okay, so the things that we can try to, or those are all also modifiable in that we can actually change them and make them more healthy. And then hypertension, we can change, we already covered that. Glucose is also a risk factor since high levels of glucose in the blood is irritating and can cause inflammation. free radicals, homocysteine, which is an amino acid that's broken down by folic acid. Um, and then high levels of it is something we naturally create in our body. And high levels of it can cause endothelial damage, leading to atherosclerosis. And then they are under the impression right now that obesity can accelerate this process. Other things that can lead to atherosclerosis that we can't really fix are going to be things like how old we are. The older we get, the more likely we have it. Males, we're not sure why. I'm not sure where that came from. Family history of CAD and being African American. We can also have an acute arterial occlusion that is just a full-blown blockage of the vessel and is dangerous, especially the higher up it goes. So we got to remember the 6 P's, which are the classic signs and symptoms of this. Pallor, they're pale, the leg is pale. Paresthesia, they're going to have like numbness and tingling. Paralysis, if they don't have enough blood flow, if it's high enough up in the leg vasculature, then they're not going to be able to get the oxygen and nutrients they need, and they can lose all ability to move that leg. Pain, especially the, I just forgot the term for it, intermittent claudication and rest pain. Poikilothermia, or being polar, being cool to the touch, and pulselessness. So if we start to notice these emergency signs and symptoms of someone who may have experienced an arterial occlusion, we're going to want to treat this as an emergency, because it is. So do things like lighten any dressings. If they're wearing a cast, cut the cast off. This patient, I think, experienced a burn. And with burns, that's a very common mechanism to cause an occlusion from the skin getting so tight around everything underneath the skin swelling up. So they may have to do a fasciotomy where they cut down the length either side of the skin to just kind of let things swell open. We may have to do anticoagulant therapy or thrombolytic therapy to break up that clot, bypass surgery around wherever that clot is, or maybe an embolectomy. Worst case scenario, we may just have to cut it off, because if it develops gangrene, then that can end the person's life. So alterations in venous flow come in a couple different flavors. We've got venous insufficiency, which it's really all venous insufficiency. And it can occur either in a superficial vessel, a superficial vein, or it can occur in a deep vessel, a deep vein. So when we have superficial venous insufficiency, I should clarify, venous insufficiency is talking about incompetent valves. So with superficial venous insufficiency, that's where we're going to get varicose veins. If we're seeing deep venous insufficiency, this is where we're going to have chronic venous insufficiency, leading potentially to deep vein thrombosis. Let's see here. So, and valvular incompetence really is what starts all of this venous insufficiency stuff, where because we have excessive pressure, potentially obesity, right heart failure. Because remember, with right heart failure, you have excessive buildup in the systemic circuit, so down by the legs. Anything that's going to be increasing the vascular pressure in the lower legs can lead to valvular incompetence. If we have enough valvular incompetence without things like wearing stockings if you're a nurse, stockings is the right term for it, like squeezy socks, what the hell are those called? Anyway, so not doing things to address it, like sort of preemptively, and you get a whole bunch of these valves screwed up. Suddenly now you get screwy, wonky valves, and you get varicose veins if it's a superficial valve that went messed up, or you end up getting venous insufficiency if it's a deep vein that was affected. And some of the things that can lead to this again, obesity, pregnancy, prolonged standing, so nurses are at risk for this. And we want to treat this by promoting smoking cessation, elevating the legs, and then exercising the legs as well to develop better um, venous return, wearing pressure stockings, and sometimes we can do elective surgery to remove these big guys. So when we have the valvular incompetence of deep veins, we can develop a lot more skin issues and edema issues. Varicose veins are really a lot more superficial, both in the way of the veins literally being more superficial, and from the perspective of how they manifest being more of a superficial thing in how they look. Um, Whereas with chronic venous insufficiency, we can get a lot more problems with um, the skin here becoming much more affected via not the bilirubin, what was it? Homocysteine? No, not homocysteine. I forgot the term for it, but the thing where it builds up under the skin because of red blood cell lysis. The edema that builds up, which can be very uncomfortable, eczema, and then ulcers. So the deep vein valvular incompetence is a more serious issue than varicose veins. Deep vein thrombosis is going to be the most concerning problem of all the different venous problems. It can occur with chronic venous insufficiency. It can also occur without chronic venous insufficiency. It may be someone sits down because of hypercoagulability. They're sitting down in a plane for a number of hours without moving, without flexing their legs to try to promote venous return. And next thing you know, they stand up. They've got this big sore spot on their calf or their thigh. It's swollen. And then next thing you know, they have problems breathing because that deep vein thrombosis dislodged and traveled up to their lungs. Okay, so blood pressure is calculated by cardiac output times systemic vascular resistance. Cardiac output itself is calculated by stroke volume, just how much blood is able to be ejected from the heart per beat, times the number of times the heart then beats per minute. And this cardiac output is going to be pretty much what determines your systolic blood pressure. Systemic vascular resistance is going to be determined by how wide are your arteries down past your heart, maybe your capillaries as well, and then how well do they constrict and dilate to accommodate the blood that's coming out of your heart. And that will determine really what your diastolic blood pressure is. So preload and afterload are a couple of really important terms. Preload is how much blood is able to get into your heart at the end of diastole. So right before the heart contracts to pump the blood out of the heart, we're measuring with preload how much blood is able to fit into the heart. Afterload is going to be then how much blood gets ejected out of the heart once the heart fully contracts. And measuring the differences between the two can help to identify different types of pathologies. So the preload is going to stretch the heart, and then afterload really is going to be also measuring how much systemic vascular resistance the person has. Okay, it's pretty much the same thing. And regulation of blood pressure comes in the form of baroreceptors, which are going to, for example, in the carotid arteries and in the aortic arch, they're going to sense a decrease in pressure, and that's going to stimulate then the sympathetic nervous system to constrict the blood vessels and increase heart rate. RAS will also then be activated by way of the kidneys detecting in the juxtaglomerular apparatus a decrease in blood pressure and a decrease in renal perfusion. And it's going to say, hey, let's go ahead and dump some renin into the system, go through the renin-angiotensin-aldosterone system, leading to vasoconstriction, a retention of sodium and water, leading to an increase in blood volume. And then ADH will be released by the posterior pituitary when, I want to say, is it the hypothalamus or is it part of the pituitary, detects a decrease in blood pressure, which will then release ADH into the system to resorb more water. Not sodium, just water. And so all of those things will help to increase blood pressure. And then natriuresis, where we've got these sensors in our heart, brain, and arteries, will detect an increase in blood pressure, and each of them will release their own different type of natriuretic peptide, which will then increase glomerular filtration rate and increase sodium and water excretion, leading to a reduction in blood pressure. Okay. And the renin, angiotensin, aldosterone system is our more long-term form of regulation. It takes a longer time to really get going, but once it does, it kind of keeps things rolling really well. And remember here that we've got realistically, okay, so the liver produces angiotensinogen on a constant basis. It's always kind of floating through the blood and just kind of sitting there ready to go. The kidneys are going to recognize that there's a low blood pressure, and they're going to secrete renin, which will convert angiotensinogen into angiotensin 1. And then throughout all of the different blood vessels in the body, in the endothelium is angiotensin converting enzyme, but in the lungs, it is a very high concentration of angiotensin converting enzyme. So while some of the angiotensin 1 gets converted to angiotensin 2 in the body, the vast majority gets converted in the lungs. So angiotensin 1 gets converted in the lungs to angiotensin 2, which then activates the adrenals to release aldosterone to cause vasoconstriction, and tells the kidneys to reabsorb more sodium and water, and I don't remember what it does in the heart. So let's see here. Hypertension. I think this was just a bunch of facts. So remember also that primary and secondary hypertension. Primary is going to be that it's essential hypertension. We don't know why it starts really. We just know that it happens a lot of times due to lifestyle modification or lifestyle issues. Whereas secondary is because of another pathologic issue such as the kidneys not working, and then you solve the kidneys and you'll solve the hypertension. Remember also that systolic blood pressure increases at this point are seen as being a stronger risk for cardiovascular disease, but there has been some research to suggest that maybe it's actually diastolic, or that diastolic has a greater issue or component towards cardiovascular disease. They're always doing research on this. Modifiable risk factors are pretty straightforward and the same as everything else. So we can have problems from hypertension to developing heart failure, developing renal failure from glomerular damage, creating problems in the eyes because of the high blood pressure affecting the really delicate blood vessels in the eyes. And then we also have the potential of creating strokes in the brain, hemorrhagic strokes, just because of the excessive pressure up there. So what we can do about it, we want to do some lifestyle modifications such as weight loss, exercise, the DASH diet, moderating alcohol, decreasing sodium, try to prevent this from getting any worse. And then if that doesn't work, we go on to pharmacology stuff. Secondary hypertension, fix whatever is the problem. So we can have a difference between emergent and urgent hypertension. It's an emergency if there's a sudden increase in BP with there being end organ damage. So If we end up having obvious problems with the kidneys because of this sudden hypertension, it's an emergency. If there's an increase in blood pressure that doesn't have any problems with any other organs that we can see, then it's just urgent and we want to definitely fix it, but it's going to be a safer fix. We're going to give medications a little slower and try to reduce the blood pressure more slowly than we would if it was an emergent hypertensive crisis. Remember, for the tests, orthostatic hypotension is specifically a decrease of blood pressure by 20 millimeters of mercury systolic and or a heart rate increase by 20 to 30 beats. So if you get up and your heart rate gets up by 20 to 30 beats, that alone is orthostatic hypotension. If you have a systolic blood pressure decrease of 20 millimeters of mercury or more by itself, that's also orthostatic hypotension. Okay, that's all pretty straightforward. If you've got orthostatic hypotension or just general low blood pressure, we want to review medications, see if anything here has caused it. Make really slow position changes, avoid any hot environments since that will cause vasodilation. And we want to teach them how to squat and bend forward when they start to notice the early signs of becoming hypotensive, and then get some compressive stockings on them to try to encourage more venous return from the lower legs, and then increase salt and fluid intake if there's no problem with like heart failure or something.